All right, welcome. Can you please tell us your name and title and what procedures, devices, or research that you work on?
Hi, everyone. I am Arif Iftekhar. I'm the principal at a medtech consulting company called Healthtech, serving various medtech startups. Before that, I was most recently vice president of research and development and program management at Endovascular, a medtech company here in Irvine, where I worked for the last 10 years on implantable devices for treating a condition known as aortic aneurysm.
Great. And what's important to know about aortic aneurysms and any other conditions that you might work with?
So aortic aneurysms are asymptomatic, meaning that the patient usually does not realize that the aorta, which is the biggest artery in the body, in their body, is slowly expanding like a balloon because of the thinning of the aortic wall. And if left untreated, it can rupture. And in most cases, it'll cause death before they can be brought to the hospital. And this is how famously Albert Einstein actually died from a ruptured aortic aneurysm. The other thing to know about aortic aneurysms is that smoking is the biggest risk factor for getting this disease. And actually, in the US, with the decrease in adult smoking, the incidence of aortic aneurysms is actually going down. Uh, with vaping, we'll have to see if that actually is a new risk factor, but it's actually a declining disease.
Oh, very interesting. And so what was historically done to treat to treat this?
So a lot of cardiovascular medicine is sort of glorified plumbing. And so this is a pipe that is about to burst. It's getting thinner and thinner and it's going to burst. And so historically, it's been open surgery to sort of cut out the aorta and stitch it up or repair it or put something in its place so that it doesn't keep bulging and is at risk of rupture. However, in the last 25 years, minimally invasive catheter-based repair of the aorta, which is called endovascular aneurysm repair, or EVAR, EVAR, has become the standard approach for patients using implantable devices that we call stent grafts.
Interesting. And so what does Elite Health do to help with these procedures and with EVAR and stent grafts?
So I have worked in this particular space for the last 17 years at Medtronic, Boston Scientific, and at Endologics, and now I consult for companies like those through Elite Healthtech. And so in those 17 years, I've led R&D teams where we design and develop these endovascular stent grafts that don't require surgery and that can treat a wide range of patients. So it's a lot of engineering around miniaturization. We take metal alloys, we take textiles, we take various technologies to miniaturize them into catheters that are then routed into the artery to the target location. So a lot of the problems we try to solve have to do with miniaturization and with pushing a catheter through the blood vessels.
Interesting. And so within this field of miniaturization and pushing catheters, what's been improved recently?
So we are right now in the third or fourth generation of devices in the vast majority of manufacturers like Medtronic, Cook, Gore, Terumo, and a few others that are operating in this space. A lot of the recent improvements in the space has focused on making the devices smaller, so it causes less vessel trauma. So in general, if you're going to put something all the way up into the artery to reach a distant site, you want it to be as small as possible. But we're treating arteries that are, 30, 35 millimeters in diameter. So how do you get such a small, how do you get such a large device into such a small artery, to get there? So miniaturization, getting them to be highly flexible and controllable, that's one area. And then a lot of improvement has also been made to make them more durable. As patients live longer, these implants that were initially designed to last 10 years to get FDA approval now have to survive 15, 20 years. So a lot of work has gone into making them more durable.
Very interesting. So you mentioned that they have to last a lot longer. What other improvements could be made? Could we see this, like, for instance, would this be possible in, say, a child or something, and then they can grow with them? Or what else? What other considerations should we think of as we're trying to improve these devices?
So, this tends to be a problem for older patients as opposed to younger patients, and as I mentioned, smoking and other risk factors. So it tends not to be an issue for younger patients. Like heart valves can be something that younger patients may need and have to grow with. Not so much with aortic aneurysms. The thing I would say here is that even though, as I mentioned, these are now in the third or fourth generation, the solution is still a rough mechanical approach. It's keeping a pipe from bursting by laying down a pipe inside a old pipe. So that's solving the immediate problem. The thing to think about for future is that the disease is still continuing. It doesn't stop. So we call that disease progression. The biological processes underlying the disease, they don't go away just because you put a new pipe in there. So I have been involved more recently looking at ways to influence the actual biology at play using biomaterials in such a way that the long-term outcomes can be impacted by the implant. And so especially at Endologics, my team and I recently got a patent on how certain endovascular devices, including some specialty biomaterials, can actually influence the biology, not just the mechanics. And for example, in this case, influence the inflammatory response, which is often the continuing disease process in aortic aneurysms.
Oh, very cool. Well, that's exciting. And then this is just the last question. What advice would you have to anyone who wants to enter your space or are graduating, students, to help them in the future to build better devices and join your team?
Well, it's really important to understand the pathobiology of disease and to understand how the body reacts to novel materials and to continue pushing the envelope on biomaterials. A lot of the existing technology is still based on nickel titanium alloys, on PTFE and on Dacron, and I believe that there are a lot other materials that can impact not just the mechanics, but as I mentioned, also the biology. And so understanding a biological approach to disease, I think, will really help engineers think outside the box of just mechanical or just electromechanical solutions.
Great. Thank you very much.